Hello and welcome to the Parkinson's Foundation Cognitive Talk Series. Today's presentation is Thinking Changes in Parkinson's, Engaging Neuropsychology. I'm Erin McGee, a program manager for the Minnesota and Dakotas chapter of the Parkinson's Foundation. Some people with Parkinson's disease experience mild cognitive impairment. The Parkinson's Foundation Cognitive Talk Series focuses on cognition concerns and challenges. Parkinson's disease is complex and can take multiple professionals to work collaboratively to deliver our optimal care plan. All the pre-recorded talks in the series are presented by one of our care team professionals who will help you become more familiar with how each can add their perspective and recommendation for optimal living with Parkinson's. Today's focus is to share the role of neuropsychologists plays in the care of Parkinson's people. In addition to the Cognitive Talk series, we are hosting virtual events each Monday, Wednesday, and Friday of the week. To learn more and to register, please visit parkinson.org/pdhealth. The Parkinson's Foundation provides families with free resources, including our website, parkinson.org, educational book series, webinars, podcasts, a hospital safety kit called the Aware and Care Kit, and our toll-free helpline, which is staffed by Parkinson's specialists. To learn more about our resources and our upcoming virtual events, remember to visit our website at parkinson.org or call our helpline at 1-800-4PD-INFO. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day Foundation, for your support. Without further ado, I'm pleased to introduce our speaker today, Dr. Travis Turner. He is Assistant Professor and Director of the Neuropsychology Division at the Medical University of South Carolina. He is also Senior Clinical Director of Movement Disorders at Versailles. He studied psychology and neuroscience at the University of Pittsburgh, earned his doctorate in clinical psychology through San Diego State University and the University of California, San Diego, and completed his internship and postdoctoral training at MUSC. He has been active in clinical and research efforts with the Movement Disorders Program for 10 years. Clinical activities include neuropsychological evaluations and focused interventions for patients with Parkinson's disease and related disorders. His research is aimed at developing new ways to measure and treat neuropsychiatric symptoms in Parkinson's disease. When he's not working, he enjoys fishing, building furniture, and spending time with his family. Let's settle in as we watch Dr. Turner's presentation, and then he will join us live for Q&A afterward.
My name is Dr. Travis Turner. I'm a neuropsychologist working in the Parkinson Center of Excellence at the Medical University of South Carolina here in Charleston, South Carolina. And I'm here today to tell you a bit about my role as a neuropsychologist and what it is that I do. My guess is that if you're watching this video, you or someone you love has been diagnosed with Parkinson's disease, and there's concerns about changes in memory or thinking that have led your neurologist to recommend a neuropsychological evaluation. Or perhaps your neurologist has told you that you must pass neuropsychological evaluation in order to undergo deep brain stimulation or DBS surgery. Regardless, many of the patients who see me aren't sure what to expect during the visit. And those that have an idea are perhaps dreading the prospect of spending hours taking challenging and sometimes demoralizing tests. And pretty much almost everyone is at least a little bit scared about perhaps getting some bad news at the end of it all. In this presentation, I'm not going to try to convince you that an evaluation with a neuropsychologist like me is actually fun or enjoyable. Honestly, it's pretty taxing, and as I often tell my patients, I wouldn't want to have to come see me. However, when we don't have a clear idea of what to expect from something, our minds will often come up with other ideas to fill that void of information. And usually, what we come up with is worse than reality. So, in this presentation, I'll first explain the role of a neuropsychologist in an interdisciplinary movement disorders team. I'll then tell you uh, what really goes on during a neuropsychological evaluation and how the results from the evaluation are used by your care team to optimize your treatment plan. And I'll conclude with giving you a few tips on things that you can do to get the most out of the process. As you may know, problems with mood and anxiety are unfortunately very common in people with Parkinson's. And many people with Parkinson's disease will also experience some changes in their ability to think quickly and clearly. Typically, this will present as absent-minded forgetfulness, maybe slower word finding, perhaps losing train of thought in conversation or difficulty with multitasking. However, none of us are perfect and we all make slips from time to time. And there's also a normal decline in memory and cognition that just comes as part of the aging process. Referral to a neuropsychologist is usually made when cognitive changes are noticed and they begin to affect a person's ability to reliably and efficiently perform tasks of everyday living. In the context of Parkinson's disease, understanding why someone is having more trouble with everyday tasks can be rather challenging because of all the interactions amongst cognitive, psychiatric, and motor symptoms. So as shown in this diagram, there's quite a lot of overlap between these domains. If someone has a lot of anxiety, they're going to be distracted by worries and less able to just focus on the present moment and the task at hand. If someone has a lot of depression, they're probably going to notice their mistakes a lot more and perhaps catastrophize the meaning of them and see a lot more cognitive problems than there actually are. It's also true that if a person has experienced significant cognitive decline, they may have more difficulty doing tasks that were once rather simple for them, or perhaps become overwhelmed and quite anxious and irritable when trying to do something that's rather complex. And we also have the phenomenon of dual tasking. What dual tasking is when a person with Parkinson's disease is trying to, say, suppress a tremor or get their hands to work and perform something that requires a lot of dexterity, they may be exerting a lot of mental effort just to make their body move the way that they want to. The goal of a neuropsychological evaluation is to understand what factor or factors are leading the person to struggle in everyday life, and when this can be identified, appropriate treatment can be delivered. So, how is this accomplished? Well, the core components of a neuropsychological evaluation include a clinical interview where we learn as much as we can about the problems a person is experiencing, followed by formal testing in a controlled environment where different facets of cognitive functioning can be examined. So first, let me walk you through the clinical interview. The focus of the interview will really be on whatever the cognitive concerns are that led the referral to be made in the first place. And so we'll ask you specifically about, let's say it's memory. What types of problems are you having with memory? What kinds of things are you forgetting? What kinds of things are you remembering? Are there any circumstances where you're more likely to struggle with your thinking than others, perhaps times of day or other environmental situations? We'll also be sure to do a very careful investigation about how these cognitive changes have impacted your daily life, the things that you're able to do or not do. Now, we're not going to do a deep dive into your psychological past. This is not a Freudian type of psychoanalytic process. That's not actually helpful. But we always do want to ask at least a little bit about mood, anxiety, and other psychiatric symptoms, because as we mentioned before, these can certainly contribute to problems with cognition. Now, if you have a care partner there or another informant, someone who knows you well and sees you on a regular basis, it's always good to get their perspective and to have them weigh in. It's never the case that one person's right and one person's wrong. It's just more information to go by so we get the best understanding of what the problems are and what they are not. After we learn about the cognitive and psychiatric issues, we'll review some more of your medical history, things that could be relevant. This could be something like history of a head injury where you lost consciousness, perhaps a time if you've ever had a stroke or experienced stroke-like symptoms. Other things such as diabetes and obstructive sleep apnea can also be relevant to cognition, so we'll probably ask you about those as well. And finally, we'll conclude the interview portion by just getting a little brief bio on you, who you are, where you're from, just a little bit of life history, so we've got a context to put everything into. Now, these interviews on the short end can take maybe 10 to 15 minutes. Typical for me is about a half an hour or so, but certainly an hour and a half is not out of the question if there's more of a complicated psychological history or social history that needs to be understood. When the interview is over, we'll excuse the care partner or the other person to the waiting area, and that's when I will begin doing the testing with the patient. Now, the testing takes a while, typically about an hour and a half or two. Nobody likes to hear that they're going to be getting tested for an hour and a half or two, but the thing is that we want to be really confident by the time we're done that we are not missing any problems that might be going on, and we're not saying things are okay if they're not, or jumping to conclusions and saying that there's a problem just because you got a little mixed up on one test. So the goal here really is to be thorough and to make sure that you're not getting shortchanged in the process. We will cover a number of different domains in a rather systematic way, and I'll just go through those with you briefly. We'll definitely look at attention and processing speed. So what I mean by this, by attention, is the ability to focus your attention on a specific task, and then your ability to sustain concentration on something usually that's rather boring. Problems with attention are rather common in Parkinson's disease, and we want to be thorough in the way that we assess them. Processing speed is kind of like a computer processing speed, and the way that we look at this is we have you do some relatively simple tasks like playing a connect the dots kind of a game, or doing things like saying what the seasons are, or going backwards through the calendar, naming off the months. We will definitely spend some time looking at both expressive and receptive language. Problems with expressive language are also rather common in Parkinson's disease, and typically this is word finding issues and being able to come up with the words you're looking for quickly. It's less common that we see people have difficulty naming objects once they're presented or comprehending speech. And it's important to look at some things that are usually not affected by Parkinson's disease to make sure that there isn't another condition going on that might explain some of the struggles a person is having. Visual spatial abilities are sometimes affected in Parkinson's, more commonly in advanced Parkinson's disease, or when a person is having visual hallucinations, we'll see problems with visual spatial functioning. And so we'll do tests where you need to make perceptions about some different stimuli that we show you, or ask you to draw things or build little designs with blocks to assess visual spatial abilities. The most common reason I would say that people are sent to see me is because of a problem with memory. Now, people can have problems with memory for a number of different reasons. And through this evaluation, we assess memory very carefully to see where the struggle is lying. If we think about what it takes to have a good memory, we first have to be alert and aroused and paying attention to what's going on around us. We then need to be able to understand what's being said. So if I was speaking in a language that you didn't understand, you'd never be able to remember what it is that I'm saying. We also have to be able to store the information that we're hearing. So the metaphors that I'll use are, if you're talking about a computer file, you need to be able to save it to a disk. If you're talking about papers, you need to be able to put them into a filing cabinet. Now, when it comes to actually remembering something, you've got to be able to find those files. So this is what we call retrieval. In Parkinson's disease, we typically see problems with attention on the front end and retrieval on the back end. If the information can be properly stored, usually some yes no recognition type questions will identify that, and people will do better when tested in that manner. The converse of this is actually true for Alzheimer's dementia. In Alzheimer's dementia, attention is usually relatively intact, but a person doesn't have the ability to store new information or make new memories. We also spend a good bit of time looking at what is called executive functioning. And so executive functions are really kind of putting all the different cognitive domains together to perform complex tasks. Okay, so the ways that we'll look at this is we'll look at things like your working memory, which is your ability to keep multiple pieces of information in mind and manipulate them. This could be doing math problems where you're adding and subtracting 3 digits, or reciting a series of numbers in the reverse order. We'll look at your ability to alternate between doing one thing and another, like multitasking. We'll do tests that require you to actually inhibit a response or to kind of put the mental brakes on a certain process. And we'll also look at things like problem solving ability and the ability to make abstract connections between different concepts. And because psychiatric symptoms are very important to consider, in addition to just asking about that during the clinical interview, we'll typically have a number of different scales where we'll ask about specific symptoms. And in doing this, we're able to, in a sense, quantify the degree of distress or the degree of symptoms you're experiencing related to anxiety, depression, or psychosis. Really, the types of questions and the types of scales that we administer kind of depend on what we learned during the clinical interview. So that's the testing. After it is all over, what we'll do is score everything up. So what this means is that we'll take the raw scores from the tests that you've completed and we'll compare them to an appropriate peer group. Believe it or not, we don't just cook up these tests in our own head. They're actually developed in a very systematic way. And prior to being used in clinic, they're given to hundreds and in some cases tens of thousands of people who are neurologically normal. This allows us then to take your scores and compare them to other people of a similar age, education, and sometimes even gender and ethnicity, because this can be relevant to what we would expect for you in the absence of anything going wrong. Once we've got these scores in hand, it's time for feedback. Typically, most patients will bring their care partner back into the room because it turns out that it's usually a good idea to have someone else there to hear what's being said. Many times when we're stressed, we don't quite hear things completely, or we might tend to focus on one little bit of information and not get the whole story. So it's always good to have the care partner in there to hear the feedback as well and to ask questions that they see as being relevant. So in doing this feedback, we'll tell you about how you performed relative to expectations. And this is going to include strengths and weaknesses. And then we'll discuss the possible causes for some of the unusual findings or the problems that we see on testing. We'll discuss any of the contributing factors, like if there was a lot of performance anxiety or if there were dyskinetic movements, the extra movements that sometimes come with taking medications for Parkinson's disease, if those could have played a role in some things. And we'll discuss other rule outs that might have perhaps contributed to the findings from the testing. Now, no one is going to leave a visit with me without hearing what my diagnostic impressions are. So we'll start, I guess, with the toughest situation. And I certainly do have some hard conversations. And probably the worst is when we have to use the word dementia. When this is the answer, it is certainly hard to hear and it's tough to deliver. But what I've actually found over the years is that there's oftentimes a sense of validation that the care partner experiences in actually hearing that word described, because the problems have been going on for quite some time prior to seeing me. The dementia didn't exist after the tests were completed. It was already there. But now that we have a word that we can use to call it that, a lot of times this leads us to setting more realistic expectations out of what we can expect in the present and what might happen in the future. It can also help people realize what resources they may need to achieve the best quality of life. Now, dementia is certainly not the only diagnosis that I give. And in fact, it's not particularly common that I actually do give that diagnosis. There's another diagnosis that's a lot more common, and that is mild cognitive impairment. And what this really means is that a person is having some struggles in day to day life. And when we do the testing, we see deficits on certain tests that oftentimes reflect what they're describing in day to day life. So if they're describing problems focusing and sustaining attention, the tests will show that. If they're having problems with multitasking, the tests will show that. This diagnosis is actually quite common. If you look at people with Parkinson's 7 years past the time of movement symptoms, about 75% will actually have this. This is very different in dementia in that people are able to do most aspects of day-to-day life. And there are certainly still a number of strengths that we can see on cognitive testing. The most important thing is that at the end of kind of going through the diagnostic impressions, we can say, all right, now that we know what is going on, let's improve upon this situation. Let's leverage the strengths and try to limit liability to whatever those weaknesses are. So some of the recommendations that will come out of this would be medications that you might want to consider taking or avoiding. I'm not a prescriber, so I don't make any changes to prescriptions, but I'll oftentimes make recommendations to the neurologist about medications they might add to improve mental acuity, or medications perhaps being used to treat Parkinson's disease that we may want to switch away from because they could be further clouding cognitive abilities. If there are problems with depression and anxiety, and I think that psychotherapy would help, we'll also discuss that. And I will tell people about what to look for in a therapist. Um, Generally, what I recommend is someone who does cognitive behavioral therapy. That's the type of therapy that has been researched the most and shown to be the most effective for addressing mood and anxiety symptoms in Parkinson's disease. The big goal here is to try to identify negative patterns of thoughts and maladaptive behavioral patterns that are leading to depression or anxiety or to a person really not living life to their fullest. It is a process of change. And I always tell people that if they leave a therapy session and they're feeling relaxed and better, they probably didn't do the work. It's kind of like going to the gym. If you go to the gym and your muscles don't feel tired, you probably haven't gotten a good workout. Change is hard. And so when you do psychotherapy, you're going to experience a bit of stress as you begin to change some of your behaviors. At times, I will have to discuss things like safety. This could be driving safety or perhaps guns, or perhaps other things that a person may be doing. It's obviously never a fun conversation. But when we see problems with attention and multitasking and visual spatial abilities in someone who also has problems with movement, that we know that those people are at a higher risk for getting into a motor vehicle accident. Doesn't mean that having those problems uh, prevent you from being able to drive, but it does put a higher risk there for having an accident. What we do in these situations is we refer someone to an on the road driving safety evaluation. I don't take anybody's keys away. The only keys in my pocket are mine, but we will make a recommendation for someone to get that assessed to see if they are safe, and perhaps get some recommendations about times when they may want to avoid driving, or changes in their driving, perhaps not driving at night so that they're safer. As I mentioned earlier, patients are often referred to me regarding DBS surgery. And so when I do feedback after the visit, I always like to tell patients what I'm going to tell the DBS team when we meet together. I don't want anyone to be surprised by what comes out of that. So whether it's positive, negative, mixed, or somewhere in between, I always let people know what I'm going to say based on the testing. I think it's certainly reasonable to ask another neuropsychologist to let you know specifically about DBS, if that's a referral issue, what they're going to say. And another recommendation that sometimes comes up will be to repeat the testing. Believe it or not, many of the patients that I see will actually ask about coming back in at some point in the future. Despite having gone through some really tough testing, they will have survived, and they may want to know, okay, well, if things are, so right now, but I'm a little worried about things being worse in the future, can I be seen down the road? In general, I don't plan to do repeat testing unless there's things that I'm concerned about or things that I want to surveil for. So if some of the situations where this could come up would be, let's say someone is working in a rather high level job, and they want to make sure that they're not caught off guard by any changes in cognition that could affect their ability to do that safely. In those situations, we may surveil a little bit more closely for any changes that could come up. Another situation where we want to look at this more closely is if there's questions about, is this Parkinson's disease, or is this maybe one of the other related syndromes, like perhaps dementia with Lewy bodies, or an atypical Parkinsonism where cognitive decline may come on more quickly, and assessing for change can help us get a better sense as to what is causing both the motor and cognitive symptoms. So that's the overall landscape for a neuropsychological evaluation. And I'd like to conclude with just a few tips on how you can prepare for one if you're ever sent for an evaluation. First, schedule for a good time of day. If you're a morning person, go for a morning appointment. If you tend to do better in the afternoon, or if you might have to drive a good distance to get to the site where you're going to be tested, go for the afternoon appointment. You should also plan for a several hour visit. Uh, for me, I always block off 4 hours. I rarely need all that time, but I like to have it in case it's needed. Generally, you should expect to be there for about 3 hours or so. So make sure that you're prepared for that and that you're not missing a meal or something else. Bring any medications that you might need to take during the visit. On that note, please be sure to take your medications as you normally would. Every once in a while, someone will come in having not taken their medications for reasons that vary, but that's never good. We want to see you at your best while you're on. If we test you while you're off, what we get is not reflective of what you're actually able to do. So please take your medications as you normally would. To the best of your ability, you should also try to get a good night of sleep. I know this can be hard, but we all do better with a good night of sleep. Any decent mattress salesperson will tell you that you spend a third of your life sleeping, and they're right, and we need that sleep. And so if you're going to be doing a lot of testing, be sure to get the best night of sleep you can. I also find it really helpful when patients make a list of concerns or questions they have that they can ask me during the visit. A lot of times people think they've got them in mind, but then they get in there and maybe they get distracted, or maybe I ask questions that take us down a different pathway in the interview, and then they leave and they have forgotten to mention something that's important to me, or they've forgotten to ask a question. Now, I'm always going to be there to answer things or to take new information into consideration after the fact, but it's always better to have those questions and any issues you might want to raise written down so that they're not missed during the visit. If by chance you've ever been through a neuropsychological evaluation in the past, it's great if you can bring in any prior reports. Unfortunately, depending on where you've been seen, it can sometimes take a week or two to get a copy of these reports in hand. I always recommend that you try to track those down as soon as possible. That way we have them and we can actually then repeat some of the tests that you did before to assess for changes that may have occurred between those evaluations. Now, if you have a care partner or someone that you know well who can provide some additional perspective, as I mentioned before, that's always really very useful. You certainly don't have to have one. It can be as private as you want it to be, but if you're okay with that, it helps us do a better job. While you're going through the testing, I would definitely encourage you to ask for breaks as needed. I'm going to be comfortable. If I need to use the restroom, I'm going to. If I need to get a drink of water, I will. You should certainly feel free to do the same and to be as comfortable as you can in a rather awkward situation. And then finally, and I think this is really important, plan for something relaxing and rewarding for after the visit. You're going to have been through a lot, and even if all you're getting is just good information and you've done really well on testing and we can say no problems, clean bill of health, it's a lot to go through. So find something that you can do afterwards to reward yourself for all the effort that you've just put in. So in summary, you already know that Parkinson's disease is not easy, and problems with mood, anxiety, and cognitive functioning can have a major impact on quality of life for patient, care partner, and all the loved ones. A neuropsychological evaluation can help identify the basis for some of the problems a person may be experiencing in everyday life. And this information can be used to direct appropriate care that helps you live your best life. And that's really what we're trying to accomplish here. So in closing, I'd just like to thank the Parkinson's Foundation for putting this program together. And I'd also like to express my appreciation to you for giving me the opportunity to tell you a bit about the work that I do and my passion for it. Thank you.
Welcome back. All right, well, that was a great video. So now we'll get started with Dr. Travis Turner doing moderated question and answer with me. Thank you for joining us, Dr. Turner.
Absolutely, it's my pleasure. Thank you for having me.
Great. All right, well, we've got some questions as people registered and questions that have been coming in during the video. So we're gonna go ahead and get right into them. The first question is about how to initiate the specific service. We have a question that came in saying, I'm seeing my neurologist every 6 months. Like, how would I know when it would be appropriate?
Yeah, that's a good question. I know that the visits with the movement disorder neurologists are pretty action-packed, and they're not as long as you'd like them for them to be. So many different facets of Parkinson's, right? And so you would want to discuss any concerns probably at the beginning part of that visit related to cognition. And any movement disorder neurologist will be able to ask some of the questions that will help delineate whether what you're describing is likely to be normal aging or suspicious for perhaps that mild cognitive impairment that I was just talking about in the video. Some other things that you can also consider is that if you're followed with a primary care doc who sees you for an annual well visit, especially if you're on Medicare, you can always request a cognitive screening there. And so that's like a very abbreviated version of what I do. And it gives you kind of a single number to give a rough estimate of where you're at cognitively. And depending on that, if it's, if it's completely fine, then maybe you don't pursue it. If it's borderline or problematic, then we can do the more extensive workup. And so that would be a good time or a good indicator to initiate services. If you're hearing concerns from other people that you're forgetting a lot, or you don't remember I told you this, or this was not quite done right, that would probably be a good indicator to ask your neurologist for an evaluation. Or if you're a care partner and you feel that the person is no longer reliable. Reliable is a term that I like to use because we all make mistakes from time to time, right? We all forget to take out the trash. We all forget to pay a bill or what have you, and maybe get distracted when driving. But if you're feeling that the person is no longer reliable and you're no longer feel comfortable with asking them if the doors are locked before you go to bed and being sure of the answer, that might be a good time to request a referral to see whether it's a cognitive issue or perhaps one of these other things that can happen in Parkinson's.
Okay. Speaking of care partners, do they attend the appointment with the neuropsychologist as well?
I love it when they do. What I usually do is I direct my questions first to the patient, get their take on things, and then I'll pretty much turn the microphone over to the care partner because they've been living with them, they've been observing them. It's not to say that one person's right and one person's wrong. It's just more information to go by. And so much of the time, the care partners will observe things that the patient isn't aware of. And it's actually far and away the exception rather than the rule that there becomes a disagreement between the two about, oh, I don't do that. Oh, yes, you do. It doesn't get that way.
All right, good to know. But I feel like one of the big pieces is making that list so that you do have those questions ready for when you have that neurologist appointment and even going to the neuropsychologist.
Yeah, absolutely. You want to have a list of the concerns. Every once in a while, someone will bring to me this almost like a diary of all the goofy mistakes a person has made in the last few weeks. And that's not real. That's not necessary. If there's a couple things that you want to kind of generally speak to, you might note them, but you don't want to have a running list of, like a list of all the grievances and things. That's not needed.
Okay, so just a few specific bullet points are all that you need. All right, question. Do you distinguish between depression and the effects of COVID-19 restrictions?
So yes, I think that we sort of can. We know that from a couple of key papers that just came out, the Fox Insight study and the study that was done by the Parkinson's Foundation, that the rates of depression, anxiety, even cognitive changes have gone up markedly with COVID restrictions. And the paper by the Fox Insight study actually showed that loss of ability to socialize was the strongest predictor of these worsening non-motor symptoms, which is really remarkable. Physical activity was also in there. It was actually fell second though to socializing. So these COVID restrictions really are huge and significant, unfortunately. My first kind of answer to that is that perhaps it doesn't matter. If you're feeling down and you're feeling really depressed, seek help. And that help may be with medication. With Parkinson's, we know that it's not just dopamine that's altered, there's serotonin that's disturbed as well. And so taking a medication that can boost serotonin is oftentimes helpful. It doesn't make COVID restrictions go away, but it maybe helps a person stop dwelling on them and thinking about the things they still can do. One thing that I've kind of looked to over the last few months and helping me figure out whether this is depression or COVID is if a person is no longer taking opportunities when they do present themselves to do fun things, to socialize safely, to exercise safely, that starts to point to depression or perhaps apathy. And also if, in those moments when there is an opportunity to have a nice FaceTime chat or to talk with neighbors in the driveway or whatever you're doing, If your spirits aren't lifting, that's likely to be more suggestive of a separate depression disorder.
Okay, thank you for clarifying. Thinking of that and where we are today, what about medications and any over-the-counter pieces that could cloud cognition? Does that come into play?
Yeah, it certainly does. So amantadine is a very useful medication for helping with motor fluctuations. It does lower a brain chemical called acetylcholine, and that can be problematic. Acetylcholine is lowered in general in Parkinson's disease. And the metaphor that I give for that is if you've ever taken NyQuil or an over-the-counter sleep aid or something for motion sickness, they work by lowering acetylcholine levels, right? So Aaron, you wouldn't take NyQuil and then try to sit down and do your taxes, right? No, I wouldn't, no. Okay, so but that can sort of be the baseline state for someone with Parkinson's disease because acetylcholine levels are lowered. Okay, that's like the mild cognitive impairment. So medications that further reduce acetylcholine can be really troublesome. That's why actually the medications that we often recommend for mild cognitive impairment and dementia raise acetylcholine levels. So that would be something like Aricept or rivastigmine. So certainly the over-the-counter medications that lower acetylcholine, you should be careful with. And what I always suggest is to talk with the pharmacist and ask them. You can go onto WebMD, but you'll get some weird stuff there. Better to just talk with the pharmacist, have the pharmacist review any medications that you're regularly taking. And if you're going to take something for, say, an allergy or for an allergic reaction to try to help with sleep or motion sickness or nausea, just ask the pharmacist. They'll be able to tell you really quickly and accurately.
Okay. I had a couple questions coming in about like a co-diagnosis. So say you have Parkinson's or Parkinsonism, and maybe some of your challenges could be related to ADD or ADHD. Would you see that present in an evaluation, or would that be a different treatment strategy?
So with the ADHD diagnosis, I'll always ask about that. I'll get some information about academic history, problems earlier on that would point to a long-standing diagnosis of attention deficit disorder. Usually that will kind of come up on its own accord as people describe the problems that they're having and say, yeah, well, this has been going on for quite a while. And that does definitely factor into the evaluation, because if there's long-standing problems with attention and an executive functioning, that kind of changes the perspective on whether this is cognitive impairment related to Parkinson's disease or perhaps something else. And that also can change how we decide to manage it. So if the person is not on a stimulant medication, perhaps we can initiate that if there's an attention deficit background. If there isn't an attention deficit background, we tend to look more towards the medications that raise acetylcholine.
Okay. And just so I'm making sure I'm tracking, after you complete the neuropsychological evaluation, do you typically have a follow-up then with your neurologist or movement disorder specialist who will create this plan?
Correct. And so what I always recommend to patients, and this is not just in my clinic, but it is in my clinic, is that after you've had the evaluation with me, don't wait for the phone to ring with the neurologist saying, you got to get in here stat. You've been diagnosed with mild cognitive impairment. We need to get the Aricept on board. That's unlikely to happen. It's unlikely that there will be follow-up until your next scheduled visit if you don't initiate it. So I always suggest give it a day, call the office, they'll get something started, they'll get things in place. And many of these things don't require another visit just to get the wheels in motion and to get my recommendations put into action. But making that call really is helpful.
Right. So being an advocate for yourself.
Exactly. Yeah, you really do have to be, even at the best centers with the most caring doctors, you still have to.
Okay, thank you. How to cope with slow thinking and response time during a group discussion is always a tough one.
It really is a tough one. because when, you have that Parkinson's is characterized by slower movement, right? That's the core feature, but there's also a very close parallel to slower thinking. It's not that a person can't reason their way from point A to point B. It just takes a little longer, right? And so with some of these fast moving conversations, especially when there's multiple people involved and it's kind of like the topic is like a volleyball bouncing around, it can be really hard for someone with Parkinson's disease to keep up, especially if they're also struggling with, say, word finding and other expressive language issues. And this, of course, is really unfortunate. It can be demoralizing. It can be socially isolating. And so what we really recommend is that you try to kind of control your environment a little bit better. Set up the gathering so that there's fewer people. Um, and allow the person with Parkinson's the opportunity to chime in, to be more mindful that they likely want to participate, but it is going to be harder. And certainly to be able to, if you're the care partner or the friend or family member, to invite that person in and request their thoughts on the matter. But really, I think it starts with controlling the social interaction in the first place to reduce the numbers. Ideally, to not have it in a noisy place either, especially for men with hearing loss. That only compounds the problem.
So would that be an example of like a recommendation you would make after an evaluation?
Absolutely, yeah, absolutely. Because there's already, the stage is already set for there to be apathy, and participating in a fast-moving conversation is really a challenge, and so it takes work, and we don't want that the work involved with that to kind of lay on top of the apathy and for the person to become withdrawn. We know that the further you step back, the more likely you are to step back even further, and that's the opposite of what we're all trying to do in helping people live their best lives with Parkinson's.
Okay, so speaking of those recommendations, do you have like a whole spreadsheet of suggestions, or how do you help people, start with a few like takeaways?
Oh, great question. And maybe I should start putting something like that together. I guess what I've really been doing in my practice is kind of tailoring them to the
Okay.
individual situation. There's certainly common themes that come up. This question about um, how to manage a social interaction when there's slower response time is a good one. I think another common theme that just helps with everything is allowing more time. Okay. So again, we have Parkinson's, slower movement, bradykinesia, core symptom. We also have bradykaphrenia, slower thinking, very common. Things are going to take longer. And so you need to give yourself more time for stuff. It is just awful to work under time pressure and in a rush. When you're like that, you're feeling anxious, you're more likely to forget stuff as you're trying to get out the door. It starts an outing on a bad note. So the best thing you can really do is just kind of step back and say, all right, you know what, it took us an hour and 15 minutes to get ready for church last week, and it was an hour and a half before then, and we left feeling stressed, and we didn't talk to each other on the way because we were both bothered and feeling bad. So now we have to realize, you know what, it's taking a while, so let's just start earlier. If the service is at 10:30, you need to leave at 10. Okay, start the getting ready process at 8. And that way there is enough time to get through things and to have everything done and not to have to feel that time pressure. So really allowing yourself the time is key and can really change the whole course of things. And it seems like an obvious solution, but oftentimes when I bring it up, people are like, very smart people are like, wow, yeah, that makes sense. But the thing is, you've been doing something for so long and it's only taking you 20 minutes to get out the door before. So why shouldn't it now? But
Mhm.
people will oftentimes butt their heads up against that. Another recommendation that's related to a question that came up here is about medications and cognition. And so certainly we see issues where people are in their off times are really not thinking well. They're thinking slower, and they're feeling anxious and just generally off. And so I always recommend that people restructure their schedule so that they're not trying to do important things during these off times or these low times. And just kind of making some of those shifts in the routine can really make a difference in how successful and enjoyable the daily routine is.
Yeah, I was going to touch on the medication piece, as we've gotten a lot of questions about that. And as you had just mentioned, restructuring or shifting, is that something the patient would work with the neurologist with as well?
Yeah, so when someone is brought to me, I'm in a consultative role. So I'm not going to start making any broad changes. I'm going to make these recommendations to the treating neurologist, to perhaps bring in a psychologist or a speech therapist or whatever the case may be. Medications also included in that. And so it's rare that I will talk about changing a medication schedule, because that's something that takes a long time to figure out and is worked out, over the years. In terms of when someone's taking dopamine, I'll be more likely to work out an activity schedule around when it's best to be taking the Cinemet and the agonists and so forth. There are times, though, when I'll make recommendations about reducing some meds that could cause the bad cognitive side effects. Like sometimes that means reducing things like the amantadine. Sometimes it could be, say, reducing things like Seroquel, or initiating those other treatments.
Mm-hmm. All right, we have time for just a few more questions. More of a clinical question. Is it possible to even separate if it's a visual or a cognitive problem when you're doing an evaluation?
Yes, it is. So with the testing that we do, we always want to test while a person is wearing their glasses, first of all. And we're looking for certain types of, I'll call them phenomenons. For example, being inattentive to one side of space or another, or to approaching copying a figure in a way that is connected to part of the brain not working very well, whether it's kind of the back part or the frontal lobes. Or whether we see disturbances of the ability to integrate various pieces of visual material. So we have tests that are helpful with this, and people even with very poor vision are able to do them well. But people with neurologic conditions, basically I'm referring to stuff behind the eye where that visual information gets processed, will have problems. So that's how we tend to tease it out. So I'm guessing that question was probably related to a person, perhaps, who's looking for things and the pen is right in front of them, but they don't seem to notice it. That certainly comes up. That's kind of a condition that men have when looking in the refrigerator, so I'm told.
I know someone like that.
Yeah, you're looking at one. But there are other things that become a little bit more than that, where you start wondering about a person's, is it visual attention or is it just basic vision? And both can be affected in Parkinson's. There's a lot more research coming in showing that actually diminished color discrimination ability is an early sign of Parkinson's, and that other problems with visual contrast thresholds, like being able to see well at dusk, are a vision problem in Parkinson's. And some people suspect that that's an actual eye problem related to alpha-synuclein in the retina. That's kind of the forefront of things. It remains to be seen whether that holds up.
Okay. All right, final question to wrap up. In your talk, you mentioned the big word dementia, if you have to share those results. How do you help people cope with that, or feelings of frustration as they've noticed they've declined, or the care partner? have any recommendations on what's next for them?
Yeah, what's next for dementia? So I think, dementia is a very big and scary umbrella term, right? And I'm also I saw some questions come up about dementia with Lewy bodies and frontal lobe dementias. There are many different types of dementias, and depending on what type it is, we can expect a different course. And so we'll start with or maybe I'll just stick with Parkinson's disease dementia, which is really kind of the transition from the mild cognitive impairment in Parkinson's disease, the absent-minded, forgetful stuff, to more significant problems where many aspects of day-to-day life are challenging, and a person needs a lot of assistance to get through the day because they're not thinking clearly. So with Parkinson's disease dementia, things will be harder. At a certain point, assistance likely will be needed for the care partner. It's too much to go alone, especially if you're talking about, husband and wife. That relationship unfortunately changes a lot with dementia. It changes from care partner to care recipient and caregiver. And that's really unfortunate because you've got however many years of marriage behind that. And the wife wants her husband, the husband wants his wife, and there's a certain amount of change that happens there. And one of my goals in kind of coming up with a plan is, how can we preserve that spouse relationship? How can we keep that the closest? Mm-hmm. Same thing, a child with a parent. How do we keep that as close as possible to really what it should be, what it has been? And that's usually where the caregiving, getting that additional assistance comes in helpful, because if someone else is able to also shoulder that load, whether it's an agency or whether it's someone else that is known, that allows for more special dedicated time for the two people to interact as they really want to, and to respect one another in their real relationship. So as I said in the video, yeah, the dementia diagnosis is tough to give. It's tough to hear, but there can be a relief. And when we get those resources brought on board, it can then create the space for a better life for both people.
Mm-hmm. Have you had any patients share, like, I started seeing a counselor, or I started joining a support group, and that helped me cope with,
Oh, yeah, absolutely. It's not just anecdotal that the support groups help. There's research supporting the benefit of that for both the patient and the caregiver. It's another one of those lifestyle choices, modifiable things that can slow the disease progression. In fact, there's the social element, and plus there's no better source for pro tips than going to one of these caregiver support groups, really. And that can be really important. And one of the sad things that does kind of happen, that I've seen in some of the support groups in my area, is that people will, with dementia, and especially with psychosis in dementia, people will step away because there's an unfortunate shame in that, as though that is like somebody giving into the illness or not having done the right things. And if you or your care, if you or your the person that you're the care partner of is feeling that way, please, keep going. Don't start isolating or step away from the caregiver support groups because things have gotten harder. To the best of your abilities, please keep going, because it really is helpful, and it's helpful for the other people too who may find themselves in a similar situation to kind of see that and to be able to help you in your journey.
Mm-hmm. Great. Well, thank you so much, Dr. Turner, for your time today. I feel like this has been a great wrap up. We had so many questions, so I apologize if we weren't able to get to everyone's. We do have some great resources on our website, and always you can check in with our helpline specialists who are trained experts to be able to help answer those questions and finding resources. So thank you again, Dr. Turner, for joining us today. And thank
Absolutely.
you to, yes, thank you. And thanks to all of our attendees on Zoom today. We'd also like to just say thank you to our Light of Day Foundation for their support. Reminder, today's session has been recorded and archived on the Parkinson's Foundation YouTube channel. And in a few days, you'll be sent an email so you can share any feedback on today's program. These evaluations help us plan for future programs, like the program coming up next week called Poetry for Parkinson's. Did you know for people with Parkinson's, reading poetry aloud may not only deepen your understanding and appreciation for poetry, but also strengthen your voice and improve speech? Enjoy the magic of poetry and bring your favorite short poem to read aloud with peers to discuss. So I hope you can join us next week. And again, if you have any questions that were not answered, please reach out to our helpline at 1-800-4PD-INFO or email at helpline@parkinson.org. You can use the same contact information to order any of our resources, our educational book series, and the hospital safety kit. All right, thank you again for joining us. And until next time, stay safe.